When you're on Medicare, you're either going to have a Medicare Supplement Plan or a Medicare Advantage Plan. In this video, we're going to talk about Medicare Supplement Plans. There are 10 of them. There's only probably 3 or 4 that you really should be considering. So we're going to go down in this video and break down exactly what you need to know and help you understand which one really makes the most sense for the coming year.
Welcome to Retirement Real Talk, where we cut through the advertisements, sales pitches, and all the confusion surrounding Medicare, Social Security, and retirement finances. Introducing the Internet's leading Medicare educator and co-founder of MedicareSchool.com, Marvin Music, and his son, certified financial planner and the co-founder of MedicareSchool.com, Joshua Music. It's time for some Retirement Real Talk.
Well, welcome to the episode. This is going to be a deep dive for all of you who really are just wondering about what Medicare supplement plan you should be on, whether you're coming into Medicare for the first time or you've been on a supplement plan or maybe been on an Advantage plan and you're wondering, well, should I get a supplement plan, and if so, which one? This video will explain all the popular plans, the pros and the cons, and really one of the things we're going to do is make sure we look at the long term. So not only what is the right plan for right now with your current health situation, the environment, but what's that going to look like in 10 years or 15 years? Because people who are on supplement plans generally are on them for a very long time because they don't like to switch off because it's good coverage. So we're going to start off with Marvin kind of going through, writing down the details of how Medicare A and B work, just briefly, because a supplement plan is designed to fill in the gaps. It's supposed to come alongside. So Medicare pays first, the supplement plan picks up what Medicare doesn't pay, and of course, differing levels of that. So it's good to have a good understanding of those gaps. So why don't you, on your iPad, walk them through that, and then we'll dive down into the plans a little bit. Hey, my name's Josh Music. My dad, Marvin Music, who's doing this video, would really appreciate it if you would like, comment, and subscribe to the video. What that does is it helps YouTube know this content's valuable, this video is helpful, and it pushes out to other people who really need to see it. So go ahead, like, comment, and subscribe, and you can get back to watching your video.
All right, as probably most of you know, Medicare is broken up into 2 parts, Part A and Part B. Part A is basically for everything inpatient, and Part B is everything outpatient, as well as doctor-related services. And whenever someone is in the original Medicare system, that just simply means that any provider they go to, they're giving them their Medicare card. And that provider is going to bill Medicare first, and Medicare is not going to pay for anything 100% other than preventive services. And so there's always a balance remaining that will be the responsibility of the patient, of the Medicare beneficiary. And so that balance remaining we call gaps in coverage. It's just simply your financial liability. And so what we have is we have 3 gaps on the A of Medicare, and we have 3 gaps on the B. So let me kind of lay these out real quickly. First of all, if I'm using Medicare A, that means I've been admitted to the hospital. And so that creates our first gap, which is a deductible. And we call this the Part A deductible. This year, that's $1,556. And that is someone's full out-of-pocket to the hospital for up to a 60-day stay. So this is going to cover anything the hospital can bill for: inpatient care, tests the hospital runs, all the facility fees, nursing services, and everything that the hospital can bill for. That deductible is the only out-of-pocket for someone that's on Medicare. Now, that deductible is unique to Medicare because it's not annual. It's something that can occur more than once in a year. So if someone's in the hospital and then let's say, 2-3 months later, they go back in the hospital, they're going to owe this deductible again. And so that's all we're out of pocket for the first 60 days. Now, if someone happens to be in the hospital longer than 60 continuous days, that takes us to our second gap, which are daily copays. Those daily copays right now are $389 a day for month 3, and then they double it to $778 a day for month 4 and month 5. Those are called extended stays. They're very rare, but when they happen, they're very expensive. And so anyone on Medicare would be responsible for that gap. And then the last gap.
So just to clarify, once you pay that deductible, that covers the first 60 days. After that, for the next month, it's about $10,000 a day, and then the 2 months after that would be, $10,000 a month, and the 2 months after that would be about $20,000 a month, right?
That's right.
So you look at 20, 40, 50, so over $50,000. If you were to just have Medicare Part A, and have an extended hospital stay, and that's out of your pocket.
That's exactly right. So,
which is, I mean, that's what the supplement plans are partially designed. I mean, they're designed to cover that. So
yeah, to fill in those gaps. And beyond hospitalization, Part A also covers skilled nursing facilities. And the way that works is Medicare says as long as someone's been in the hospital 3 days or longer, they can then go to skilled nursing, and Medicare covers everything for the first 20 days. So the first 20 days costs someone on Medicare nothing. It's zero out of pocket. But after 20 days, if someone still is in need of care, Medicare covers us for another 80 days. That's days 21 to 100. And they pay everything but a daily copay. And right now, this year, that's $194.50. And so if someone's in beyond 20 days, they're going to be out of pocket about $200 a day. They tell me right now the average is about 30 to 35 days in skilled nursing. So most people today on Medicare are going to be out of pocket $2,000 or $3,000 to the skilled nursing facility. So the whole point is that's the gaps on A. The gaps on B, very simple. We have a deductible. This deductible is not and cannot occur more than once in a year. It's a calendar year deductible. So that's $233. This deductible does reset every January, so it can go up. Sometimes it remains flat. But after we've met that deductible, that brings us to our second gap, which is 20% coinsurance. So anything Medicare covers on the B side, they pay $80, and the Medicare recipient pays 20%. This actually is our biggest gap in Medicare because it's unlimited. In other words, that 20% never, ever, ever stops. It just keeps going. And the biggest issue here is this is where the doctors are paid. Yeah. So when we have someone that has a serious illness, they've certainly seen multiple doctors about that illness. And then if they're in the hospital, every doc that sees them in the hospital, if there's a surgery that occurs, that surgeon's paid the 20%, the anesthesiologist. So this is where people really get hurt on Medicare if they don't have other insurance.
And I feel like this is, people hear like 80-20 plans, and a lot of, I think the plan I'm on is 80-20 plan, but there's a maximum on my 20%. So if I had $1 million worth of bills, maybe my max is like $3,000 or $4,000, $5,000 that I would have to come out of pocket. On Medicare, in that scenario, you're on the hook for the 20%, and the sky's the limit. It literally goes forever. And that's definitely the biggest risk.
Yeah, there is no max out of pocket. It just keeps going and going. Yeah. And then the last gap on the B side of Medicare is when someone goes to a doctor that actually will see them as a Medicare recipient, but they have not agreed under contract to take Medicare-approved reimbursement amounts. We call that assignment. And when a doctor doesn't take assignment, they're going to add to the bill 15%, and that's called an excess charge. And if and when this ever occurs, this would be the responsibility of the Medicare recipient. And so that's our third gap on the B of Medicare. So as you can see, we have 6 gaps. And so the majority of people that stay in original Medicare are not comfortable with this amount of liability. So the insurance companies give them the opportunity to be able to transfer that liability to an insurance company. The insurance company takes the liability. Of course, we have to pay a premium for them to take that liability. All right, and so right now, as Josh said, there's 10 plans that are available. Frankly, 95, probably 97% of all people are going to get one of 3 plans, and so we'll kind of detail those plans.
Yeah, I did want to clarify. So for excess charges, so that's where the doctor charges 15% above what they can. There's no max on that either. So really, if you just had Medicare A and B, you're on the hook for 20% unlimited, plus all those other deductibles, and an additional 15 unlimited. There are some states that don't allow Medicare excess charges: Ohio, Vermont, New York, Minnesota, Connecticut, Rhode Island, Pennsylvania, and Massachusetts. But all the other states do charge an excess. And I think it's important to say, like, not every doctor by any means charges an excess, but as Medicare, if they cut doctor reimbursement rates, we kind of expect to see more excess charges in the future. So again, we're looking out long term. What some of the supplement plans cover those excess charges, meaning they pay for it, some do not.
Right. Yeah, and statistically, right now, it's about 1 out of 10 doctors on average is going to charge excess. Now, you go to Mayo Clinic, all the doctors are going to do that, and Cleveland Clinic and some of these specialty places, cancer centers, they almost always add the excess. So if someone's going to get into some real serious care, there's a high likelihood they're going to go somewhere where they're going to experience an excess charge unless that state will not allow it.
Okay, so we've heard this 1,000 times. So, I'm just going to go to doctors that don't charge excess. And I know you explained that pretty well. What would be your response to that?
Mm-hmm. Well, you can certainly ask if a doctor does or does not take it, and they have to tell you. It's not like they're going to hide it. And so I think it is possible for someone to do that. However, they're going to limit themselves. If they're in some serious situation, they need to go to Cleveland or Mayo or MD Anderson or someplace Well, if they don't get a plan to cover excess, they will have to pay the excess charges. And frankly, the reason a lot of doctors don't do this is because it does upset their clients, their patients, and so they avoid doing it. But if Medicare does lower reimbursement rates, we could see this happening more frequently. And the whole point is it doesn't cost a whole lot of money, an insurance premium, to be able to get excess charges covered if and when it does occur.
Okay, so we have an understanding of the gap. So let's talk about the kind of the gold standard, the platinum, the Plan F. That was the Cadillac plan for years and years and years. We helped thousands of people buy Plan Fs because it was the best thing out there. The Plan F, you can think of it as a full coverage plan. So all of these gaps that we wrote down here, the Plan F paid all of them. Right? You did not get a bill if you were on a Plan F. And a lot of people are still on Plan Fs, and they love them because they never got any bill. Everything was always 100% taken care of. But Medicare basically said, hey, we're going to withdraw this plan from new beneficiaries. And when did that start?
In 2020.
So if you were not already eligible, so here's a good question. Who can get a Plan F today? Because some people still can.
Oh, sure. Anyone that was born before January 1st, 1955, which meant they were eligible for Medicare before January 1, 2020, can still buy F plans and can keep F plans their whole life.
Should they?
Well,
I mean, if you're new to Medicare.
In most areas, it doesn't make financial sense to do that. I would get the next best thing to the F plan, which is the G plan. And so I think there are some that, they like the full coverage aspect, but the problem is they're paying too much for it. Because in most states right now, people are going to pay at least $50 a month more for the F plan versus the G plan. Right. So what they do, they paid $600 in premium for the year, and they got a $233 benefit.
Right. So let's talk about the Plan G.
Yeah.
The Plan G is identical to the Plan F in terms of you can go to any doctor you want that accepts Medicare. It covers all of these gaps except for one, and that is you are responsible now for the Medicare Part B, as in boy, deductible.
That's
so
right.
This year's $233. So again, Plan F full coverage, Plan G 100% coverage, right after you pay that $233 deductible, which is why you're saying if you're on a plan, if you have the option to get a Plan F, you probably still ought to look at a Plan G because you're going to save $50, $75, $100 a month, and the only difference or only financial liability you're picking up is going to be that Part B deductible. So what would you say to somebody who's on a Plan F right now, because there's people watching this that are on or listening to this that are on Plan Fs, what would be your counsel to them? Because I think, and I've seen this so many times, hey, I love my Plan F, don't ever get rid of it. What would your counsel be to them as they're thinking through the Plan F, Plan G, Plan N?
Right. Well, the F is for life. They can keep it as long as they want. The problem is twofold, really. Number one, the group that they're in, because everyone that gets a supplemental plan goes into a group, and that group is an older group. That group is switching plans. People are passing away, and so that group is getting smaller, and the result of that will be less stable rates. So that's one issue. The second issue is some people won't be able to move from an F to another plan because they can't medically qualify. And so if they have some serious health issues, they're going to have to stay on their F, and that's all right. It's a great plan.
Yeah.
But if we can get someone through underwriting that their health is decent enough for us to get approval, then I think it's very wise to go to the G plan. Number one, you're going to save substantial money monthly, more than enough to cover the B deductible. Plus, you're restarting. Now you're in a younger group of people that are primarily 65, a larger group because most people are going on G plans, so they can really reset the clock, and that will result in more stable rates for them for the long term.
Okay, so let's talk a little bit about price stability. If you want to flip to a new sheet on that, we kind of need to talk through it for our audio only listeners. But if you think about joining a rate pool, right? So think of a big box, and you're going to join a rate pool, and there's going to be a lot of insured people in that rate pool. So what's happening right now is people are on Plan Fs. If they can go, so the age of that group is getting older, and insurance, right? They presume as you get older, there's going to be more health issues and more claims. So those rates start to go up. The other thing that's happening is we've seen for the last several years, all the healthy people who are on Plan Fs are switching out of Plan F and going to Plan G, which is further making the Plan F rate pools just more and more unhealthy, which means there's more claims, which means those premiums are going to go up. So if you're on a Plan F for the long term, if you're healthy, it's a good idea to look at a G. So let's talk about price stability a little bit.
Sure.
As it relates to that.
Yeah. So someone goes into a group, or we call it a block of business. They come in based upon usually their age, their gender, and their tobacco status, and where they live. And so that's the initial premium that they're going to receive. And so what happens is everyone in this block, of course, different genders, ages, and all that. But what is happening in the block is this. The policyholders are paying in their premium. And most people pay through a bank draft today, so money goes into the group. And we've transferred the risk of these gaps to this insurance company, so obviously they're paying money out. So what happens is we have money going in and money going out. And so we have claims would be the reason that money is going out. So money goes in through premiums and money goes out through claims. And so what happens is eventually more claims will go out than premiums coming in. That's going to happen with everything. Why? Because of medical inflation. And so that's when these groups begin to take price increases whenever they begin to lose money. They have the right to go to the state insurance commissioner, petition for a rate increase. So let's keep it simple. Let's say that there comes a year where they're losing 5%. Well, insurance companies are protected by law. They don't have to lose, so they will petition the insurance commissioner for a 5% increase for that group. The insurance commissioner usually approves it, and so what they have the right then is to raise everybody up in this group 5%. And so what really determines these price increases like this, it's the health of the group.
Right.
And so if we've got a tremendous amount of cancer going on and hips and knees being replaced and things happening, we're going to see more price increases. So the way to mitigate for this price increase is to be in what we would call a large block company. And so we know that companies that are larger, more national companies, since it is regional, we know there's going to be more policyholders in this group. Therefore, the risk is spread out to more policyholders. So the impact upon health problems will be less substantial with a larger group plan. Sometimes a company may have lower rates to attract policyholders, but they're regional and they're smaller. Guarantee it, those companies are going to go up more drastically, more frequently.
Yeah.
So we have just learned that price stability comes when we have a larger block company, so that risk is really spread out to more people.
Yeah, a lot of your smaller, like regional supplement plan carriers, they just are not price stable because they have 5,000 people in their block, whereas you look some of these national companies have millions of people in their rate pool, and it just leads to an overall much more stable rate. Okay, so that rate stability thing that applies to all the supplement plans. So let's talk about, we've talked about Plan F, full coverage, the Plan G, which a lot of people have, definitely the most popular supplement plan today, is the Plan G, but a close second to that is going to be Plan N. And so why don't you maybe discuss the differences between Plan G and Plan N, because that's probably maybe people's biggest question they have today is, I've decided I don't want an Advantage plan, I want to get a supplement plan. If you're in that camp, now do I go with a Plan G or a Plan N? And I want to preface this by saying we'll talk about the benefits, but there are some states where it definitely makes sense to get a Plan N over getting a Plan G. For instance, if you're in a state that doesn't have excess charges, and I think New York, it's like $100 cheaper to get a Plan N versus a Plan G. There's just not really a reason to get a Plan G. So we're going to paint with some broad strokes here, but it's important that you understand your state specifics, and call and talk to one of our Medicare guides. We can walk you through what really makes sense for your situation in your state.
Hey, if you need help getting your Medicare all set up and making all those decisions to make sure that you have the right coverage, we would love to help you. In the pinned comment section below, you can see a link there. You can actually set up an appointment to meet with one of our Medicare guides. It's a virtual appointment, and they will help you from A to Z, do everything that you need to do, from enrolling into Medicare to selecting the right Medicare plan, so that you'll have confidence that you have the right coverage for your situation.
Let's talk about the differences between Plan G and Plan N.
Okay. Just real quickly, obviously the F plan covered all gaps, right? So it's full coverage. We know that as long as Medicare pays, F follows. The G plan paid everything except for the B deductible, right? And so that's $233.
Right.
That just simply means the first $233 and anything on the B side is going to end up as a bill in their mailbox. They're going to have to pay for that. The in plan has a couple gaps. You're responsible for the B deductible, $233. We're also responsible for the 15% excess charge if and when that occurs. F and G cover excess, but N does not. Okay. And then we have a couple co-pays that we're responsible for. We're subject to a $20 copay, up to a $20 copay if we go to the doctor, or if we go to the emergency room, we're subject to a $50 copay to the ER. Mm-hmm. So we have a few more gaps. We're responsible for some more liability, but as you said, in some states there is a substantial difference between the G and the N. Now the problem comes if someone happens to be in a state that doesn't charge excess, but they have to go to a state where that's allowable. And they go to Mayo, or they go to Arizona or someplace where they can actually charge that excess. So that's what they have to decide. But I think both are wonderful. I think everyone has to decide financially, what they're most comfortable with, because there is no, good or bad or right or wrong here in this scenario. But that's the difference.
Okay, so we have a pretty highly educated audience that listens and watches our content. And one of the things that people ask me pretty frequently is, hey, I watched a video on YouTube about how the Plan N is going to be better than the Plan G because, and this is where their wrong assumption is, because they have derived from these videos that everyone can get a Plan G all the time without any health questions asked because it's a guaranteed issue plan. That is completely wrong, completely wrong. The fact of the matter is there is a very, very, very small subset of people that in very specific circumstances, for instance, they took A and B and had a retiree plan, but now that retiree plan they want to get off of. They qualify for a special period to be able to get a supplement plan with those no health questions asked. That's called a true guaranteed issue status. And in that scenario, again, tiny subset of people, minuscule, they really have to get the Plan G. And so the idea is, well, there's all these people that are obviously unhealthy that are getting on Plan G that can't get on a Plan N. So by nature of that, we're going to see the Plan G prices shoot up. And I just think that's completely wrong. I mean, it just doesn't make sense.
Mm-hmm. Yeah.
We help 1,000 people a month, and we have like one of those cases a month, two of those cases a month. It's like saying, dumping a cup of water into the ocean is somehow going to make it bigger.
Yeah. Well, most people are getting their Medigap policy when they're first going on Medicare. And that includes healthy people and healthy people.
Yeah.
And they can get the N plan or the G plan.
Yeah.
They just can't.
Either
so
plan.
It's open to them. So you're right. It's just a few people that were already on Medicare A and B, and now they are going to go to a different plan, and they can get a G without any underwriting if they're coming off an employer plan or retiree plan. But it's just not that many people.
Okay, we get some more questions on like K and L, and I'm not even going to take the time in this video to address them. The reason for that is there's like 4 people in the last 10 years that have bought one of these plans. I'm exaggerating, but it's hardly anyone. Mm-hmm. And why would you want to go into an insured pool of people and there's only like you and your cousin and his dog that's in the insured pool? Like, even if that plan looks good and that insurance company in your area is trying to make that price competitive to suck some people into that, you're just entering such a small rate pool that if 2 of them get cancer, all of a sudden whoosh, you've gone up a lot. So we're not going to spend a lot of time addressing K and L. If you want to add anything, you can. Yeah. The other one is high deductible Plan G. We get people asking us about high deductible Plan G. And it's not a bad plan. Some people are just more prone to say, hey, I want a high deductible plan because that's what I had at work. And that's just what I'm used to. So why don't you address high deductible Plan G? Some of the people, maybe stories that you've seen, or we've seen that happen over the years of people who started with that and then kind of had some stuff come up.
Right. Well, anytime they have a high deductible G or a high deductible F, if they were born before January 1st, 55, they have to meet their deductible before Medicare is going to pay anything. So deductible, co-insurance, co-pays, right now it's $2,490 a year. So you divide that by 12, we're talking a couple $100 a month. And so what happens on those plans is they're going to meet the deductible, and then usually people want to get off of them once they get sick.
Yeah.
And now they have a problem because the only way to get off of them is to go through underwriting. And so they are going to be on the high deductible plan the rest of their life.
And I think the point, and this is just something that's kind of been an epiphany to me lately, is people who are saying, well, hey, that's what I was on, with my group plan. Okay, great. So what happens if you had a health issue that came up on your group plan? Well, during your next open enrollment period, you check the other box, and all of a sudden you have this great plan, and it costs you a little more in premium, but you have a health issue going on, so you're going to get that other plan. In Medicare, it doesn't work like that. Oftentimes, the plan you chose, if you have a health issue come up, that's your plan, and that's your plan for maybe the rest of your life, or at least 3, 4, 5 years. So anyway, high deductible Plan G, you can get it. It's not generally something we recommend. So supplement plans are great insurance. We definitely do more supplement plans or help more people into supplement plans than we do Advantage plans. And if you're trying kind of on the fence, you're trying to decide, hey, what supplement plan really makes best sense for you? We're going to tell you to find an independent broker that you can work with that will show you all the options that are available in your area, go over long-term price stability, kind of talk to you through, hey, Plan G, Plan N, which one makes the most sense for me, and then help you get enrolled. So if you don't have an independent broker that you want to work with, instead of working through call centers and all this stuff, give our team a call. You can schedule an appointment on our website. We'll have a pinned comment below. You can schedule an appointment right with our team. And our promises to you is we're going to shoot straight with you. All of our Medicare guides, which is what we call the agents on our team, we don't pay them more or less depending on what plan you enroll in. So it's a flat rate thing. So they have no bias in their advice, which is something that's very important to us. Our first core value is we always do what's in the client's best interest. And so if you need an independent broker to work with, we'd love to be that resource for you.
Yeah, and I should also want to remind our audience that when you work with any agent, whether it's independent broker or captive, whatever, the price is always the same. You're not going to save any money by going with one versus the other because the insurance commission is paid by the company, not by you. And so it's truly a free service. So that's something that we think you can take advantage of, and we'd be delighted to help you.